I'll start by introducing our first presenter, who's Cristina Mussini from the Icona cohort in Italy, who will be presenting to us today on the prognostic value of FIB4 in HIV-positive patients in the Icona cohort co-infected with and without hepatitis C.
Thank you, Marina. Thank you, Marion. And I want to thank the organizer for choosing our work to be presented today. So we're talking about the prognostic value of FIB4 in HIV-positive patient of the Icona cohort, co-infected or not with HCV. Liver-related death due to viral hepatitis, either C or B, or metabolic complications still remains a main cause of death among patients with HIV infection. FIB4 index is a non-invasive serum fibrosis marker which has been validated in HCV-positive patients. Aim of the present study is to evaluate the prognostic role of FIB4 at starting ART and during treatment to predict major liver events or liver-related death. We retrospectively enrolled patients from the Icona cohort, which is a peculiar cohort enrolling only patients naive to antiretrovirals. And to be included in the analysis, patient had to have a known HCV serology to be negative for hepatitis B, with at least an available FIB4 index at starting ART and during follow-up. We calculated FIB4 as usual with age, transaminases, and platelet counts. We analyzed FIB4 both as continuous variable and as divided in categories as follows, as already published. FIB4 values above 3.25 as a proxy of cirrhosis, FIB4 value between 1.45 and 3.25, in which cirrhosis status is considered as undetermined, FIB4 values lower than 1.45 considered as absence of cirrhosis. Time of starting antiretroviral was considered as baseline, and patients were followed to the date of the first major liver event or liver-related death. Major liver events were as follows, and the follow-up was censored at last clinical visit, at the event, or at death for causes other than those liver-related. For statistical analysis, we calculated the incidence rate as number of major liver events or liver-related death divided by person-year follow-up. We used the multivariable Cox regression model to determine the association of FIB4 with the risk of major liver events of liver-related death. And as I said, FIB4 was used both as baseline and time-updated covariate. We included in the analysis 3,475 subjects with the inclusion criteria that I said. And these are the general characteristics of the study population at baseline, so at starting ART. 73% of the patients were males. The mode of HIV transmission reflected the Italian epidemiology with heterosexual, but also a high percentage of intravenous drug users. Concerning HCV seropositivity, 27.2% were positive, and the FIB4 index was below 1.45 in 66% of the patient, and a proxy of cirrhosis, so above 3.25 in almost 8% of the patient. We also evaluate blood glucose and cholesterol. So this is the Kaplan-Meier showing the cumulative proportion of patients experiencing a major liver event or liver-related death after starting ART according to baseline CD4. As you can see, we had 41 events during 18,662 person-year of follow-up, and this is the description of the event. We had 16 liver-related death, and we have 25 major liver events, in particular 15 decompensated cirrhosis, 5 hepatic encephalopathy, 2 gastrointestinal bleeding, 2 hepatocellular carcinoma, 1 hepatorenal syndrome. This is the incidence ratio of major liver events or liver-related death stratified by HCV serostatus and FIB4 index at baseline. As you can see, among the HCV negative, we had 6 events with an incidence rate of 0.5. Among the positive, 35 events in a much shorter follow-up with an incidence rate of 5.9. And concerning the FIB FIB4 index, we had 0.5 in a patient who had a baseline FIB4 below 1.45, while we had 14.6 in those who had baseline at 3.25 and above. These are the Kaplan-Meier of the HCV negative subjects and of the HCV positive subjects. So we conducted a univariable Cox regression to understand the factors or the variable associated with major liver events or liver-related deaths. As you can see, being intravenous drug user was associated as the length of time of HIV diagnosis, and also the HCV positive status, seropositive status. The higher FIB4 was at baseline was associated with the endpoints, and also the progression of FIB4 during the follow-up was associated. The alcohol consumption was associated only if it was a daily use, and the current HIV RNA was associated, while the current CD4 was protective concerning to the endpoints, the clinical endpoints. When we perform the multivariable Cox regression, and we also adjust for age, sex, mode of transmission, time from diagnosis, CDC stage at diagnosis, calendar year at CART initiation, we see that HCV seropositive lost the association, so the significant association, while FIB4 at baseline, especially in the higher values, is still associated as the progression of FIB4 during the follow-up. And the current CD4 maintained the protective role. So in conclusion, in HIV-positive individuals, FIB4 at baseline and its modification after CART initiation are predictive of major liver events or liver-associated death, independently of infection with HCV, and could be used as surrogate markers of severe clinical events. So in patients with HCV, or those with HCV RNA, FIB4 could be used as a simple marker to prioritize HCV treatments in the HIV population. I want to thank all the patients enrolled in the Icona Foundation Study, all the centers participating, some of them are present in the room, and in particular Antonella D'Arminio Monforte, who coordinates the cohort, and Massimo Galli and Adriano Lazzarin also for the support. Thank you very much for your attention.
The paper is now open for questions. I believe there are microphones down on each side. I can't see very well, perhaps while we're waiting for somebody to come to the microphone, I did have a question. You looked at antibody positive participants in the cohort. Do you have information about hepatitis C PCR positivity, and assuming that these are chronically infected or not?
No, in this preliminary analysis, we did not, I mean, we know that there's a data gap in the cohort, so not all these patients had HCV RNA evaluated, so that's why we are doing a new analysis on this.
And Christina, do you know the patients who are HCV antibody negative with a high FIB4, what was the etiology of their liver disease?
No, we didn't do this specific analysis. This is really a preliminary one. We didn't expect these results because we had a high number of patients who acquired HCV through intravenous drug use and also HIV. So we thought that it was mainly due to this. As we have some results that we have to confirm, because there was no association with blood glucose, for example, where in the literature we know that the OMA score, we don't have the data on insulin resistance, but we know that the NASH is really one of the cause of the progression of fibrosis. So we are evaluating, but I think that the result is interesting because also HIV by itself, by the action on stellate cells, could make the fibrosis progress. So we will see what's turned out from the new analysis.
Yeah, go ahead.
So I have another question. In your abstract, you said you had 400 and something who had HCV RNA viremia, and if you compared those and their outcomes to the non-viremic, what did you find?
At present, we don't have the data collected. I mean, we have some data, but since we didn't have the new drugs, the data on co-infection are not so well collected in the cohort. So we could not discriminate between those who have an HCV RNA negative because they have been treated, and those who had an HCV RNA negative from baseline. So we could not perform this analysis yet, but we are really looking forward to do it.
Okay.
If there is somebody out there, they can jump in, because we certainly can't see you. It's kind of blinding up here.
That's why I have my hand just looking out at the audience.
No, nobody at the microphone.
All right. I think there's no further questions. Thank you very much, Christina.